let me be real with you for a second. If you are over 60 and taking blood pressure medication, there is something your doctor has probably never sat down and explained to you. Not because they are hiding it on purpose, but because the medical system is busy, appointments are short, and there are things that simply do not make it into the conversation. But what is not being said could be quietly affecting how you feel every single day. And I am not talking about rare side effects listed in tiny print on a package insert. I am talking about real, documented changes that happen inside the aging body when it interacts with the most commonly prescribed drugs in the country. One major study found that over 40% of adults over 60 who were taking blood pressure medication were experiencing symptoms they never connected to their pills. They thought it was just aging. They thought the fatigue, the dizziness when standing up, the foggy thinking, the muscle weakness, all of it. They assumed that was just what getting older feels like. But here is what is wild. For many of them, it was not. So stay with me through this entire video because by the end, you are going to understand your medication, your body after 60, and your options in a way most people never get the chance to. Let us start at the very beginning. Because to understand why blood pressure pills behave differently in bodies over 60, you have to understand what actually changes as we age. And this is something most doctors do not take enough time to explain. After the age of 60, your kidneys begin to filter blood more slowly. Your liver, which is responsible for breaking down medications, starts processing drugs at a reduced rate. Your body fat percentage tends to increase even if your weight stays the same, and body fat holds certain medications differently than muscle tissue does. On top of that, the number of water molecules stored in your body decreases, which means medications that dissolve in water become more concentrated in your bloodstream than they would in a younger person taking the exact same dose. Now, think about what all of this means. A pill that was designed and tested primarily on middle-aged adults will behave differently in a 65-year-old body. It stays in the system longer, it hits harder, and the effects, both the intended ones and the unintended ones, are amplified. This is not speculation. This is basic pharmacology that every physician learns in medical school. But somehow, the follow-up conversations with patients rarely reflect this knowledge. Now, let us talk about the most commonly prescribed classes of blood pressure medications and what each one actually does inside your body, because understanding this will help you recognize things you might be experiencing right now that you have never connected to your pills. The first and probably most widely prescribed group is called ACE inhibitors. You might know them by names like lisinopril or enalapril. These drugs work by blocking a specific enzyme that causes your blood vessels to tighten. When that enzyme is blocked, the vessels relax and your blood pressure drops. Simple enough in concept. But here's what most people are not told. ACE inhibitors also affect how your kidneys hold on to potassium. And after 60, when your kidney function is already slowing down, this can lead to potassium building up in your blood. Too much potassium, a condition called hyperkalemia, can cause muscle weakness, unusual fatigue, and in more serious cases, heart rhythm problems. A significant number of older adults quietly walk around with elevated potassium levels and have no idea because the symptoms are vague and easy to dismiss. They feel tired. Their muscles feel heavy. They assume it is just their age. But the connection to their ACE inhibitor and their aging kidneys is never made because nobody checked. The second major class is called beta blockers. These include drugs like metoprolol, atenolol, and carvedilol. Beta blockers work by slowing your heart rate and reducing the force with which your heart pumps. For many people, this is exactly what is needed. But in older adults, there is a very real and underappreciated risk. Beta blockers can mask the symptoms of low blood sugar, which matters enormously for the millions of older adults who also have diabetes or are borderline diabetic. Normally, when your blood sugar drops too low, your body gives you warning signals. Your heart races, your hands tremble, you feel sweaty and anxious. Those are your alarms. but beta blockers suppress those signals. So a diabetic older adult taking a beta blocker can slide into dangerously low blood sugar without feeling the warning signs that would normally prompt them to eat something or seek help. And beyond the diabetes connection, beta blockers are also linked to something that rarely gets discussed openly, and that is their effect on mental sharpness. Multiple research studies have found that older adults on long-term beta blocker therapy score lower on cognitive tests compared to peers not on the medication. Not dramatically lower, but measurably lower. Slower processing, slightly reduced memory recall. Again, if you are 65 and you feel like your thinking is a little cloudier than it used to be, your first assumption is probably that it is just aging. Your doctor's first assumption might be the same, but the medication connection deserves to be explored. Let us move to the third class, which is calcium channel blockers. Amlodipine is probably the most recognized name here, and it is one of the most prescribed drugs in the entire country. Calcium channel blockers work by preventing calcium from entering the muscle cells of your heart and blood vessel walls, which causes those muscles to relax and your blood pressure to fall. For a lot of people over 60, these drugs are genuinely effective and well tolerated, but there is a side effect profile that gets glossed over in a lot of medical appointments. Calcium channel blockers, particularly the ones in a subclass called dihydropyridines, are notorious for causing ankle swelling. Not dangerous swelling in most cases, but uncomfortable, noticeable and frustrating swelling that can affect your mobility, your shoe fit, and your daily quality of life. Here is where it gets interesting, though. When older adults complain to their doctors about this swelling, a common response is to add a diuretic, a water pill, to flush out the excess fluid. So now you are taking a second medication to manage a side effect of the first medication. This is called a prescribing cascade, and it is more common in older adults than most people realize. One medication causes a problem. A second medication is prescribed to fix that problem. The second medication then causes its own side effects. Sometimes a third medication follows. And at no point in this chain does anyone step back and ask whether the original medication is truly the right fit. The fourth class is diuretics, specifically thiazide diuretics like hydrochlorothiazide. These are often called water pills because they make you urinate more frequently, which lowers the volume of fluid in your blood and therefore reduces pressure. On paper, this sounds straightforward. In practice, for someone over 60, diuretics come with a cluster of risks that are frequently underappreciated. First, they deplete the body of certain electrolytes, most importantly, potassium and magnesium. Low potassium causes muscle cramps, weakness, and heart rhythm irregularities. Low magnesium, which is already deficient in a large percentage of older Americans even before any medication is involved, affects everything from sleep quality to blood sugar control to nerve function. Second, diuretics increase the risk of dehydration in older adults who already have a diminished sense of thirst compared to younger people. Your body stops sending you the thirst signal as reliably after 60. Add a water pill on top of that, and dehydration can sneak up on you quietly, affecting your energy, your kidney function, your blood pressure readings, and your cognitive clarity. Third, and this one is critically important for fall prevention, diuretics cause a drop in blood volume that can lead to something called orthostatic hypotension. That is the medical term for when your blood pressure drops sharply the moment you stand up from a seated or lying position. You stand up, and suddenly the room tilts. You grab the counter. You wait for it to pass. Millions of older adults experience this regularly and attribute it to getting older. But for many of them, it is a direct and preventable consequence of their medication. Now, here is where the conversation needs to go deeper, because we have talked about individual medications, but the reality for most people over 60 is that they are not on just one blood pressure drug. They are on 2, sometimes 3, and the combination effects are where things become genuinely complicated. When you combine a diuretic with an ACE inhibitor, you significantly increase the risk of kidney stress. When you combine a beta blocker with a calcium channel blocker, you increase the risk of your heart rate dropping too low. When you add a potassium-sparing diuretic to an ACE inhibitor, you dramatically elevate the risk of dangerous potassium levels. These are not rare or exotic combinations. They are given to people every single day, and the individual prescribing each piece might not have a full picture of everything else the patient is taking, especially when different medications come from different specialists. There is also a deeply important question about what blood pressure target is actually appropriate for someone your age. For decades, the medical community pushed for a blood pressure target of below 120/80 for nearly everyone. More recent research has complicated that picture significantly for older adults. A large and well-publicized study called the SPRINT trial found that aggressive blood pressure lowering in older adults did reduce cardiovascular events. But it also found that aggressive treatment was associated with a higher rate of serious adverse events, including kidney injury, low blood pressure episodes, and fainting. A separate analysis looking at adults over 75 found that the benefits of aggressive blood pressure control were much less clear-cut for people who had multiple health conditions, or what doctors call frailty. The point is not that blood pressure control does not matter. It absolutely does. High blood pressure remains one of the leading contributors to stroke, heart attack, and kidney disease. The point is that the right blood pressure target for a 72-year-old who is otherwise healthy is not necessarily the same as for a 45-year-old, and the conversation about what your specific target should be deserves more individualization than it typically gets. So, what can you actually do with all of this information? Because the goal here is never to alarm you or to push you towards stopping medication on your own. That would be genuinely dangerous. But knowledge gives you power in the doctor's office, and most people over 60 never use that power because they do not know what questions to ask. The first thing worth doing is what some doctors call a medication review. You sit down, ideally with your primary care doctor or a pharmacist who specializes in this, and you go through every single medication you are taking, its dose, how long you have been on it, what it was originally prescribed for, and whether that original reason still applies. Studies show that a meaningful percentage of older adults are taking medications that were started for a temporary condition years ago and were never stopped. Blood pressure, in particular, can change over time. People who lose weight, change their diet, reduce stress, or increase physical activity sometimes find that their blood pressure naturally comes down to the point where their original medication dose is now too strong. The second thing worth exploring is how your medications are being monitored. Are you getting regular blood tests that check your kidney function, your electrolytes, your potassium and magnesium levels? Because if you are on a diuretic or an ACE inhibitor, and you are not getting those labs checked at least once or twice a year, important things can be drifting in the wrong direction without anyone noticing. This is not paranoia. This is basic monitoring that is recommended in clinical guidelines but does not always happen consistently. The third area worth raising with your doctor is the timing of your medication. Many blood pressure drugs are taken in the morning by default, but there is growing evidence, including from a large study conducted in Spain, that taking blood pressure medication at bedtime rather than in the morning may actually reduce cardiovascular risk more effectively for some patients. The reasoning is connected to your body's natural blood pressure rhythm. Blood pressure typically rises sharply in the early morning hours, which is a key window for stroke and heart attack. Taking medication at night means the drug is actively working during that critical morning surge. This is not a universal recommendation, and whether bedtime dosing is right for you depends on the specific medication and your health profile. But it is a conversation that is worth having. And then there is the lifestyle side of the equation, which is not a replacement for medication, but is a powerful complement to it. The DASH diet, which emphasizes fruits, vegetables, whole grains, and low sodium, has been shown in multiple clinical trials to lower blood pressure by amounts comparable to a single medication in some people. Regular aerobic exercise, even walking 30 minutes most days, has measurable blood pressure lowering effects. Sleep quality matters more than most people realize. Poor sleep raises cortisol, which raises blood pressure. Even consistent, moderate reductions in sodium intake, which for most Americans means simply cooking more at home and eating fewer processed foods, can produce meaningful drops in blood pressure over time. None of this is magic, and for many people with significantly elevated blood pressure, medication is absolutely necessary and life-saving. But the lifestyle piece is often mentioned briefly and then never followed up on, when in reality it deserves serious attention and support. Let me tell you about something that gets almost no airtime in these conversations, and that is the psychological dimension of long-term blood pressure medication use. Studies have found that older adults who feel like passive recipients of medication, people who were handed a prescription and never truly understood why or what alternatives exist, are less likely to take their medication consistently, less likely to report side effects, and less likely to make the lifestyle changes that could actually reduce their dependence on medication over time. Feeling informed and in control of your own health decisions is not just emotionally important. It has measurable effects on actual health outcomes. Patients who ask questions, who understand their treatment, and who have real conversations with their doctors about their goals and concerns do better across nearly every measure. So, the single most important thing you can take from this video is the permission and the encouragement to have those conversations. To walk into your next appointment with specific questions. To say, can we review all of my medications together? To ask, are there side effects from these drugs that might explain how I have been feeling? To say, given my age and my overall health, what blood pressure target actually makes sense for me? You deserve answers to those questions. Not a rushed dismissal, not a prescription refill without a conversation. Real answers. And if your current doctor does not have the time or inclination to provide them, that is valuable information about whether you might benefit from seeking a second opinion or from asking for a referral to a geriatrician, which is a doctor who specializes specifically in the health of older adults and who is trained to look at the full picture of your medications, your physical condition, and your quality of life together. Now, I want to hear from you, because the experiences of people living this every day matter more than any clinical study. Have you ever experienced a side effect from a blood pressure medication that you initially dismissed as just aging? Have you had a conversation with your doctor that felt genuinely thorough and informative about your blood pressure treatment? Or has it mostly felt rushed and incomplete? Have you made any lifestyle changes that noticeably affected your blood pressure readings? Drop your experience in the comments below. This is a community where real conversations happen, and your story might be exactly what someone else watching this video needed to hear to finally ask the right questions at their next appointment. Share this video with someone you love who is over 60 and taking blood pressure medication, because the information in this video is the kind that takes years of experience to piece together, and most people never get the chance to hear it laid out this clearly. And if you found this valuable, subscribe to the channel because we cover exactly these kinds of conversations every week, the things that matter most to your health after 60 that simply do not get enough attention anywhere else. Your health is worth understanding, and you are worth the full conversation.